All right. I don't know if we have the online audience yet, but I think we should just pretend like we do and plow ahead. And then I think we do have the online audience. So, folks, if you're here, welcome. If not, we'll see you soon. All right. Thank you for joining us today. Hope you all, got a little, exercise there, get the heart rate up a little bit, go up and down some steps. Little excitement never hurt anybody. All right, fantastic. So we've got a real treat for you today, folks. So you're going to hear today from Dr. Reza Seyedsadjadi, and he is a neuromuscular neurologist at Massachusetts General Hospital right here in Boston, as well as being at the Harvard Medical School. Okay, Eric, do we have the online audience? Okay, great. So, all right, Max, why don't you do the introduction? All right, thank you.
So my name is Max Barrientos. I'm one of the board members and a patient of the CMT Research Foundation. It's my pleasure today to be here with Dr. Reza Seyedsadjadi. Thanks, Doctor, for being here. So Dr. Reza is a neuromuscular neurologist at the Massachusetts General Hospital, an assistant professor at the Massachusetts General Hospital. He's the director of CMT clinic at the MGH and part of the Inherited Neuropathy Consortium. His clinical and research focus is on disease outcome measures and clinical trial readiness. So with that introduction, I will leave Dr. Reza.
Thank you so much. Honored to be here. This is a very broad topic. I'm not sure if I will be doing the justice, but just talking about it, but I'll keep it brief. And I'll mostly talk about from my perspective, because I'm mostly a clinician and seeing patients in clinic. And I listened to the earlier to the talk, especially with Stefan, talking about genetic testing or more testing. But this is something that comes with patients in every clinic about what's your way of thinking about diagnostic approach? What are you doing? What's the next step? Why am I doing this test? So I'll try to answer these questions, though I'm not sure if I'll be, again, doing the justice, I apologize. But, and then give more time for questions. So let me advance this if I can. Right. So when somebody comes to clinic, usually there are some expectations that I try to address. The first one is usually, is that what's my diagnosis? That's the first question. That's very important because there are more commonly patients present with lifelong history of progressive weakness and balance issues, but not everybody reads the same textbook. So some diseases, some types of hereditary familial neuropathies can present with different courses, especially in pediatric population. Sometimes you see a very different sort of disease course. The disease could be relapsing and remitting in nature and how it presents, like having improvements and worsening over time. And it can be...
Rekorda kan man tydligen, men här kan du ju då göra chatten. Ja. Det är väl ungefär som att vara inne på det andra, vad det nu heter. Ja, här står det ju.
Man kan du rekorda också.
Sorry, should I...
So those who are online, you can mute the mic.
Or do you want me to mute people from here? Sorry.
I think we're good. Otherwise, we can mute.
It's all right. Okay. So, but overall, also knowing what diagnosis you have would be. Yeah, I think we should mute all because getting a lot of feedback. Okay, my apologies. So it also dictates what sort of research is going on that potentially patients are interested to participate in. But overall, for the general patients, the management may not be entirely different for the most patient population in terms of tools that we have to improve gait, usually bracing, or some sort of exercises to improve function, and also some exercises, especially not some certain types of CMT, to improve the hand function. So why do I want to have a type or know a type? So there are some points to this, and most importantly, patients report that this helps with their having better knowledge is power. Essentially, it'll give you more information about seeing the course in other patients, know where you're heading, whether this particular mutation has similar penetrance in different generations, they would have similar type of disease, or is it possible that, let's say, female carriers may have milder form of disease or no disease at all. It will help us rule out other diagnoses, mostly in pediatric population. It can happen that patients present with progressive neuropathy, and you wonder about chronic inflammatory neuropathies like CIDP that could be potentially treatable with steroids or some other immunomodulatory treatments, and earlier diagnosis obviously would avoid further testing or even unnecessary treatment. It could be potentially harmful. It can also help with knowing the risk of passing on to the next generation. It's an autosomal recessive condition. There's less chance of having passing it on to the next generation unless you have a carrier partner, or also autosomal dominant or X-linked, and those can help determine whether making plans with regards to family. And then talking about treatment and options, and now you heard all about new treatments and research being done in the field, developing new options, and that's also going to be an important aspect of knowing what type you have. So the clinical approach in general is that you see a patient, you clinically suspect that they would have a hereditary familial neuropathy. Nowadays, we used to do a little bit more in terms of clinical evaluations, but nowadays we either follow with the suspicion of CMT or any neuromuscular condition with neurophysiology, which is EMG, nerve conduction study. Or sometimes if you have a strong suspicion and you already have a family history, you go straight to genetic testing these days, now that it has become more available. So neurophysiology helps you understand if patient has a nerve disease or a CMT, and sometimes some mimics that are actually muscle diseases that we used to make, we sometimes see presenting similar to some types of CMT. And again, depending on the type, you can decide whether to do more testing, genetic testing specifically to diagnose. So it used to be pulling teeth, doing genetic testing a few years ago, and there were multiple publications by our colleagues in terms of deciding or making diagrams of what's the nerve conduction velocity. If it is less than 15, you first test for CMT type 1B. If it is between 15 and 25 velocity, you test for CMT 1A. If it is positive, go this. If it is negative, like this. There were like flow charts of how to do this. But now for the fraction of cost, now genetic testing is available nowadays, and it's, in some cases, is actually for free. And what we talk about this genetic testing is a targeted sequencing, and we'll talk about that a little bit more. So there are different scenarios that happens with the targeted sequencing. These are usually called panels that between 70 or 50 to 100 genes that have been associated with different types of CMT. Some are actually more definitive, more evidence, and some of them are not necessarily, they're like reports of possible association with different types of CMT. This targeted sequencing specifically looks at those areas that have been identified as part of the Sorry, I keep muting. Is that okay? Yeah. So there are three different scenarios that happens. We do targeted sequencing. You either get positive test results or get negative test results. And more commonly or so, you get what you call as variant of unknown significance or inconclusive. So I'll talk briefly about three different scenarios and probably give you a couple of examples of when or how we solve those issues in clinical setting. It's not as sort of straightforward. Sometimes it would be a little bit complicated. Sometimes even when you get a positive genetic testing does not necessarily mean that you carry the disease. It's sort of, you have to see in the context whether what's the penetrance of that mutation, whether that mutation, or what's the evidence for that particular mutation that is causing the disease. So not necessarily positive testing means that you definitely have the disease. And we've recently been seeing this in prenatal screening with patients who present with positive genetic testing for CMT1A. They don't have CMT1A, but there's a duplication, but it's an area of the gene that does not cause CMT1A. So if you do the targeted sequencing and get the response, which is usually around between 50 to 60% of patients who come with suspected hereditary neuropathy, you most likely belong to the bigger group of CMT1A and then the more common types of CMT that are listed here. And about like roughly around 10 to 20% belong to the other group that have been published, that we call them others, and usually different publications. So there are debates whether the genetic testing or targeted sequencing, whether you should focus on these more common types versus going to include all types. But I think that discussion is becoming less and less relevant as genetic testing is becoming more and more available. So statistically speaking, about 60% of still patients who have positive genetic testing have CMT type 1A, followed by other types. So, and it's also important to know that in addition to more than 100 genes that we have described to be associated with different types of CMT, we also have different types of other hereditary neuropathies and overlap syndromes that they could present in a very similar pattern and fashion. So we have hereditary sensory autonomic neuropathies. We have hereditary motor neuropathies that are relatively overlap with CMTs because there are some genes that would also cause both phenotypes or debated phenotypes. And we have overlap syndromes, something that is fairly common we see in CMT clinic, which I don't think I included here, are like different types of hereditary spastic paraplegia. So they may present with distinct foot morphology, which is shared with patients with CMT, slightly different phenotype. And sometimes it's difficult to distinguish between a pure CMT from HSP or CMT-HSP spectrum disease, or sometimes you call CMT-HMN-HSP spectrum disease. So, so those are other types that are not necessarily part of the targeted sequencing panel. And if there is a clinical suspicion that you may carry one of those mutations, obviously you have to do more testing. And every time a genetic testing comes back negative, you always think about the possibility that what if this was not the right diagnosis? What if there was something required neuropathies? What if this was a muscle process? What if this is like a central process? So the second scenario happens when you do the targeted sequencing and you get variant of unknown significance or inconclusive. There's like a mutation, it's pathogenic, but you only have one copy of the gene that doesn't cause the, explain your presentation. In those cases, you usually do two strategies. One would be to do sequencing from the family members to see if unaffected or affected family members carry the same mutations. Obviously, there are pitfalls there. It's not like 100% that everybody who does not have the mutation has the mutation should have the disease. But it gives you a gist of whether you think that mutation is relevant to the clinical presentation or not. Then there are functional studies. This is mostly done in research basis, at least for now, but it could be something that really relevant to the specific mutation. I'll give you an example shortly. But these variants of unknown significance could also be a problem, because if they are not solved, they are always the question remains whether this is specific, and sometimes it will be very difficult to solve some of these mutations, whether this is actually relevant to the presentation or not. And there are like debates whether or how much you should pursue further evaluation. That depends on the clinical scenario, obviously, and varies from one case to another. So I wanted to tell you about this. I don't think that this makes a lot of sense to most of audience, but these are nerve conduction studies, or EMGs, from a 30-year-old gentleman who presented with progressive neuropathy. So what is on the right side panel shows actually some signature that you see in the context of if you have inflammation in your peripheral nervous system. It's a condition called chronic inflammatory demyelinating neuropathy, which is more acquired process and responds well to immunotherapy. So this patient did not respond to immunotherapy. He was started on IVIG and steroids, and he was seen as a second opinion by another colleague who noted that maybe there is some distinct foot morphology, not very high arches, but maybe a little bit. So he pursued genetic testing in 2018, and this came back positive for one single mutation in FIG4. That mutation does not explain your clinical phenotype. You need two abnormal mutations for that condition. But given that actually in that particular type of CMT, which is CMT type 4J, you can have EMG findings similar to CIDP, and he was not responding to treatment. So we pursued more testing. And this was actually collaborating with our colleagues, Jun Lee, who kindly did looked at the expression of FIG4 in fibroblasts from this patient, which was reduced. So this was followed by the same panel only a couple of years later, and found actually he had a second mutation, which was missed in the first testing. So also technology changes with regards to the testing. Sometimes the very same targeted testing few years later could capture the mutations that were not captured previously. So this was helpful in terms of his clinical diagnosis and the clinical course with regards to also knowing the chances, risks, and family planning for this gentleman. So the third scenario is that when you get targeted sequencing, but you don't get any response. So your test is negative. And that's about 50% of patients who present with clinical CMT. You do the genetic testing and you don't get an answer. That is commonly asked by patients. And that doesn't mean that you do not have CMT, but that means that probably we haven't been able to identify the mutation that you have. I'll give you, and that merits sort of doing more genetic testing. Now, we all listened to the nice discussions earlier on today about the usefulness of whole exome or whole genome sequencing in terms of research, making us better understand the genetics, not only for specific type of CMT, but overall how we have peripheral nerve disease, and also identifying new mutations. But before going further, I wanted to also give you another example, and I think that would be interesting to see. So these are two patient siblings that were seen by different colleagues in our hospital. They both presented in their youth, in their 30s, with, again, clinical presentation of progressive neuropathy, and they were both diagnosed with chronic inflammatory demyelinating neuropathy, CIDP. And then both of them were treated with IVIG and then continued to progress. And it was not until both of those colleagues left and we inherited those patients. And it didn't make sense for two siblings to have CIDP. So we did genetic testing, which was negative, but the targeted sequencing. And obviously, neurophysiology was not helpful because all responses were gone by the time that we did this study. But it was whole exome sequencing that solved the mystery that they both had a homozygous mutation in MME gene. And that's why they presented. And later on, actually, we learned, and it's not shown here, that there was a family history of consanguinity. So this raises an interesting point about doing more testing early on, or also raising the point about getting a better family history or clinical history when patients present. But this gene was not part of targeted testing when we did this study of whole exome sequencing. Now it is in most of the panels. So what is more sort of comprehensive testing do? And is it really going to change the management? And that's what most patients ask. This is the first question they ask, and probably that's the first thing that they have been told when they were the first approach. They said, okay, so we're going to do the, and that's most common that you get from insurance companies when you do prior authorization. How is this going to change your management if you know if you have specific mutation? And the answer is that it depends, because there are multiple factors that are important to know why you have this. Is most importantly, I think I have a different slide on this, sorry. So most importantly, it would help you decide about knowing, obviously, what type you have will help you in terms of your genetic counseling, family planning, and avoid unnecessary testing and treatments, and also knowing about the research and potential treatment targets. But there is also a risk that you still will not have an answer, because although we are getting this data, processing it could be complicated, especially whole genome sequencing. And would need not only resources in terms of financial resources, but needs manpower and people who are trained to do this type of work, and also identifying new mutations. And also there's a question which is debated, other findings or unwanted information. So here in the States, at least, there's a question about whether there is a mutation is found incidentally that you don't really want to know. You can say that you don't want to know that mutation, for instance, a gene that could cause cancer. So it could potentially have implications with regards to the life insurance or disability insurance, especially if somebody young and asymptomatic. So these are things that should be considered when ordering it. And often we have better chance with having a better discussion with the patient through a genetic counselor rather than doing it, especially in the clinical setting, directly. Also better chances of getting insurance approval. Tony nicely, Marina earlier mentioned about the scope of whole exome sequencing and whole genome sequencing. Obviously, one is better, bigger, but not necessarily better in all cases because of the issues about availability, cost, and a slowing process. But the whole genome sequencing is the trend with regards to finding better or more mutations. I love Stefan's, this is from one of his HSV papers, I think, his graph showing the gap between what we have been so far able to identify, what's the trajectory of what we will identify through Mendelian genomics or single genes that would cause the disease, and what are the potentials and what we can find through whole genome sequencing and not, or maybe bigger data to answer some of the questions in patients who have suspected neuropathy, and some explanations why we haven't been able to identify these. But I think for the most part, bigger data would lead to better sort of assessment of other factors or genetic factors that are contributing to neuropathy. So these works, I think I would mention the nice work that has been presented a few times. And again, I wouldn't be doing a good justice on this, of pursuing whole genome sequencing through the same project from Stefan and Andrea, that they identified nicely the SORD neuropathy, which is potentially treatable neuropathy. Now they're doing a clinical trial through Applied Therapeutics. This is one of the success stories of doing whole genome sequencing and using the brain power and manpower to sort of bring it from an early diagnosis to a clinical trial stage in a very short period of time. So So the part that I really didn't talk about was the first part of the presentation, which was other types and what if I don't know my type thing. So the first part is the other types and what if I don't know my type, which is about 50% of, I would say, total patients with CMT. But looking at like different meetings and talks, including this meeting, and I was looking at the abstracts from PNS meeting with regards to potential therapeutics, roughly 50% of what you read is about either treatments about other types of CMTs and or downstream effects of genes that could be shared between different mutations or even not known types of CMT. So I think I would look at the positive side that although we are doing a lot of emphasis, you hear about they're doing different trials or studies about CMT1A, CMT1B, CMT2A. There are a lot actually shared with other types of CMT, which could be applicable between platforms to even types that we don't know about. So I didn't give any specifics about other types, but happy to take questions or.
That would be great. And I think we're going to open the online for questions as
Sure.
well. One thing is, folks, please ask questions here. The online audience will not be able to hear those questions.
Okay.
So if you could just restate them.
Yes, absolutely.
Of the 50% that the genes don't identify, what percent of those do you think that had whole genome sequencing?
I don't know. It's a difficult question because I would say I can say what percentage of my patients in clinic have done whole genome or whole exome sequencing, but I probably wouldn't be able to give you a number of what in across country or in general in my clinic. So I have done probably 20%, 20 to 30%. Absolutely.
You were just talking about whole genome sequencing and the percentage of patients that you see in your clinic. You specifically see in your clinic that have had it done. But my question is, what is the deciding factor? Is that patient driven, they request it, or is there something clinically that you see that makes you say we should do whole genome sequencing instead of just running the CMT panel through GeneDx or whatever?
Right. So the question is that in terms of the practice scope that we have in our clinic, what is the main driving factor in determining whether to pursue further genetic testing? Or their whole exome sequencing, whole genome sequencing. That varies from one scenario to another. If there is something actionable, for instance, if there is a question about somebody who's having a more progressive course and we're trying to sort of rule out a possibility of a hereditary neuropathy, and that's going to change the treatment plan dramatically, or there is a plan, family sort of planning. Sometimes in pediatric patients specifically, I sort of push to do whole genome sequencing and usually do it through like patient's insurance and commercially. Because that's also another question, because sometimes it's difficult to get insurance approval. But if somebody or anybody with types of CMT who their targeted sequencing has been negative, we are part of the Inherited Neuropathy Consortium. So what we do is that we offer the studies that patients can participate in, including the study that we work with Dr. Zuckner's team, and whole genome sequencing is part of that study. So we enrolled them in the research study and send samples to the University of Miami. The caveat is that usually on research grade, although you get a better resolution, and you're able to actually look at the data yourself and determine what genes could be potential explanation, it takes longer to get sequencing done on the research protocol compared to the clinical grade. But also clinical grade is available when you can get the raw data and upload it to the same platform too. That we do too.
Phil was diagnosed. He found out from doing the test. It's one of my sequences that they found it. Unknown, significant, and they eventually diagnosed it with CMT2S. But we still don't know what about it. And that's what they said, that she only presented on one gene that I have. And I'm a carrier, and hers is progressive. We need to know more. And we fought to find out that she had CMT2S, and that's what's causing the part of her hands. Toes. I couldn't afford it. She was.
Is it a condition you take medicine for?
No, we know that already.
Yeah. Yes. So
Just
no.
slow it down.
So we've actually got a researcher here who studies CMT2S, Dr. Shibi Vikitay. So Dr. Vikitay, would you like to say a few words?
First of all, thank you so much for letting me be here. This is exactly, I think, what I was hoping for, to meet all of you in person. And I took a picture of your slide, doctor, because there was a small gene of IGH-MBP2 right there, which we also actually work with. Yeah, so so I'm from Nationwide Children's Hospital. We do, fortunately, we're able to start one of our first phase 1/2A clinical trial for SMART1 and CMT2S as of last year. We'll be more than happy to talk with you even after I'm here throughout the evening. The one thing I wanted to also mention was the variants that you actually mentioned. So the variants of unknown significance. What we have been able to do in our lab, so I work with Dr. Catherine Meyer, we also work on in vitro disease modeling. So in these cases, what we are able to do is actually take the patient skin fibroblasts and convert them into disease-relevant cell types to then study what could be actually some of the mechanisms or some of the pathogens for that matter. So that's also again like through the patient resources. As far as the SMART1 IGH-MBP2 is concerned, we were able to, thankfully, so my PhD mentor, Dr. Brian Caspar, so he had his early work on developing gene therapy for IGH-MBP2. That is the similar concept that we are able to actually take it into the clinical trials now. And as you mentioned, depending on the severity, it could be either SMART1 or CMT2S. So we hope that the same therapy would be beneficial for both the patients. And again, like we'll be more than happy to actually talk after the conference also. Thank you.
Other questions in the room?
I don't. Thank you very much.
And should I get comments or questions from, or I don't know how it works here. Is there a?
Yeah, you know what? We actually have somebody.
Who's doing that? Okay.
Cogniform,
Okay.
in the background working on that.
Okay. Perfect. Yeah, sorry.
No. First of all, thank you so much for coming and giving this talk. What do you think the standard of care is nationwide and the penetrance of using this sort of panel testing to diagnose people with CMT? Because in our experience, it's kind of been like, oh, do some basic neurological testing, then do like a single gene panel, and then, well, we don't know which type it is, so like, see you later.
Right. Or the question is that is the type relevant? Is it going to change the management? And that's changing. Yeah, I think it's variable. From patients that I see, I think it's very variable. Most sites are not really doing it, but recently with more genetic testing or more free genetic testing, essentially, it's becoming more frequent. But that's a good point. I mean, education plays an important role in terms of people pursuing further testing and getting a confirmed diagnosis. Thank you.
So what would you suggest if you have a history of it in your family? Would you suggest that all of your children are tested? Because obviously the earlier that you get it and have some answers, the more you can treat it and hopefully slow it down, correct? You're not going to cure it, but you can slow it down.
So that's also an interesting question, depends on the clinical scenario. So let's say if there is a condition like CMT2S, when you have like a more severe sort of presentation earlier on, and there is a potential intervention, even on research basis at the moment, that could potentially stop or rescue the clinical phenotype. The earlier you diagnose, the better it is. But that's not necessarily true for more common types of CMT, especially if you do not have clinical presentation in pediatric patient population, at least. There are some ethical considerations before doing genetic testing if you are an unaffected minor. No, it's just no, I think it's the ethics of genetics in general. So if you are a minor here, at least, if you don't have any symptoms, I don't think that you can. You can, but there are some ethical considerations with regards to doing genetic testing in minors who are asymptomatic.
But even though, for example, family of 6,
right,
start with my mother, and then 4 of my siblings have it.
Right. So knowing it early is better. So in those cases, what I practically do is that I clinically monitor everybody. And as soon as I see signs that are suggestive, we do genetic testing. But sometimes, actually most of the time, if somebody, let's say, has CMT1A, for instance, is a more common type of neuropathy, if clinically you've been tested and you have the condition, clinically your children develop the symptoms, they have it. So they clinically you can say, or at least electrophysiologically, you can say by a very basic EMG, you can say if they have the condition or not. You don't necessarily need to get genetic testing.
I just have one more question. You were talking about high arches. So if you have a high arch, you're more apt to get it. So if my kids have flat feet, they don't have to worry about it?
No. Unfortunately, not. Yeah. So, yeah, foot morphology changes when you're younger. 1, 2. I usually some people say like foot deformity. I don't like that term. It's like a distinct foot morphology. And it could be flat feet. It could be high arch. It could be different presentations, even in the same family. And also high arches can be seen in general population, 7% or 10%. Plus, it can be seen in other heredofamilial conditions or non-heredofamilial conditions as well, like cerebral palsy, HSPs, some other conditions could cause high arches. And so it would be more a combination of exam, and depending on the clinical scenario, maybe even a brief EMG can help determine in terms of knowing it depends on again, the specific type of CMT. It can help differentiate, yeah.